Hello, my name is Andrew Nish. I'm the Medical Director of the John Stoddard Cancer Center and an interventional radiologist. And I'm going to talk today about some of the values that you'll see on your lab results. Now, as we draw lab results, I want you to remember that these results are based on 95% of the population falling within the normal range. So we're going to go through different lab results, talk about why they might be low or why they might be high. This is not designed to be a comprehensive analysis of any lab results, but just to give you some common factors that can result in abnormalities. So the first thing we'll talk about is sodium. Sodium is a positively charged ion in your blood. It's the most common or highest concentration ion in your blood. Sodium can be elevated with dehydration, which would be a common cause, GI losses, diarrhea or vomiting, and it can be also associated with abnormal secretion of something called antidiuretic hormone. Low sodium can be a result of cirrhosis, congestive heart failure, hypothyroidism, and in many patients, particularly those who take thiazide diuretics, they can cause a decrease in sodium concentration in the blood. The next lab result you'll see is potassium. Potassium is the most common intracellular ion. 98% of all potassium is within the body's cells. Abnormally low potassium can be seen with diuretic use, can be seen with vomiting, can be seen with something called hyperaldosteronism, where you have an abnormal tumor of the adrenal gland that causes low potassium, can be seen with diarrhea as well. Elevated potassium most commonly can be seen with kidney failure, where your kidney fails to secrete the potassium that it normally would in the urine. Can also be seen with tissue breakdown, so anything that causes tissue damage can elevate your potassium. Chloride. Chloride is associated with alkalosis, which means an abnormally high pH in the blood. This can be seen with vomiting. That will decrease the chloride. Elevated chloride can be seen with anything that causes acidosis, so anything that makes your blood more acidic can cause elevated chloride. And that includes ketoacidosis in diabetics, lactic acidosis, which is something that occurs when there's tissue damage or death, can also occur with diarrhea or renal failure. Carbon dioxide. So carbon dioxide is a byproduct of cell metabolism and energy production. Elevated carbon dioxide can be seen in people with respiratory diseases such as COPD and emphysema, where we retain carbon dioxide. Decreased carbon dioxide can be seen in people with what we call a metabolic acidosis, where they have an acid pH due to some type of cellular death, and the carbon dioxide lowering compensates for that. Glucose. So glucose, we all are interested in glucose because we're associating glucose with diabetes. So the most common reason for an elevated glucose is diabetes or prediabetes. And this should be really paid close attention to. We have over 30 million diabetics and another 8 to 10 million prediabetics. So it's important to look at blood glucose. Decreased blood glucose can be seen with critical illnesses, can also be seen with alcohol use, and rarely with tumors of the pancreas called islet cell tumors that produce insulin. Blood urea nitrogen, which on your lab test is labeled BUN. So urea nitrogen is a breakdown product of protein. So anytime we see a low protein state, such as malnutrition or overhydration, we can see decreased BUN. Most commonly, elevated BUN is secondary to renal failure, can be seen with dehydration, can be seen with large protein loads. Creatinine. Creatinine is a breakdown product of muscle. Okay, creatinine is filtered by the kidneys, but it's not resorbed, so it's a really good measure of kidney function. Creatinine can be seen elevated in patients with kidney disease, can be seen with dehydration, an elevation in dehydration, and can be seen in shock states where there's low blood perfusion of the kidneys. Decreased creatinine can be seen in people with decreased muscle mass, cachectic people, malnourished people, people with muscular dystrophy. Calcium. We've all heard about calcium. You need calcium for bone formation. Well, your bones are the largest store of calcium in your body. So we can see increased calcium with what's called hyperparathyroidism, where there's an abnormal tumor in the parathyroid glands which results in mobilization of calcium from the bone and elevated serum calcium. We can also see elevated calcium in patients who have cancer that's gone to their bones. We can see elevated calcium in people who take too much vitamin D and too much calcium supplements. Low calcium, this can be seen with hypoparathyroidism, where the parathyroid glands don't work. We can also see low calcium in what's called tumor lysis syndrome, where people are being treated for tumors and we get marked lysis of cells, and that can decrease the calcium. We can also see decreased calcium in patients with pancreatitis. Phosphorus. So phosphorus goes hand in hand with calcium. It's also regulated by the parathyroid glands, but it's just the opposite. So when people have high calcium, they typically have low phosphorus, and people who have low calcium, they typically have a higher phosphorus. So with low phosphorus, we can see that with people who abuse alcohol, we can see it in burns, we can see it in malnutrition, and we can see it in hyperparathyroidism. High phosphorus we see with renal disease, we see it with hypoparathyroidism, and we can see it in a state of acidosis or low pH in the blood. Uric acid. We've all heard of uric acid, it causes gout. But why do we have high uric acid? Well, one of the biggest causes of high uric acid is sugar in our diet. Part of the metabolism of fructose, which is a part of the molecule of sugar, is through the liver, where you produce large amounts of uric acid. Also, diets high in meat can produce excess uric acid. So those people who have obesity or metabolic syndrome have high levels of uric acid and are predisposed to gout. So if you want to lower your uric acid, lower your sugar intake. The next one on the list is cholesterol. We've all heard of cholesterol. It's this evil substance that causes all kinds of diseases, including stroke, heart attacks, and things. Well, it's not that simple. A total cholesterol number is actually quite a meaningless number. And people want to say, well, my cholesterol's high, therefore I'm at risk for cardiovascular disease. It's more complicated than just total cholesterol. So I would warn you not to use total cholesterol as a marker of a significant disease state. 90% of all cholesterol is produced by our liver. Only about 10% actually comes from our diet. So you really can't change your total cholesterol much by changing your diet. But there are reasons to change your diet other than cholesterol. Total protein. This is a measurement of all the protein in your body, and there's three main classes: albumin, globulins, as well as fibrinogens. So total protein is not really a marker of any specific disease, but it may be an indicator of some underlying problem. So cases of decreased total protein occur with malnutrition or malabsorption syndrome, such as celiac disease or inflammatory bowel disease. Can also be seen with kidney or liver disease. Elevated total protein can be seen with something called amyloidosis, can be seen with multiple myeloma, can also be seen with viral hepatitis. So just remember, total protein is not a specific marker for any disease state. It just tells us how much protein is floating around in your blood. The next one on the list is albumin. So albumin represents about 50% of all total protein. Albumin is produced by the liver. It's a marker of liver disease, so we see decreased albumin in cirrhosis. We see decreased albumin in patients with kidney disease who spill protein into the urine. We call that nephrotic syndrome. We can see decreased albumin in patients who are malnourished, particularly patients with cirrhosis and malabsorptive syndrome such as celiac disease. Cachectic patients in cancer typically have low albumins. Elevated albumin is really an unusual problem. We can see it with severe dehydration, and we can see it with really high protein diets. Next on the list is total bilirubin. So bilirubin is a breakdown product of red blood cells. That breakdown product is metabolized by the liver, and then that bilirubin is excreted into the bile, which goes into your bowel. Elevated bilirubin can indicate blocked bile ducts, either from stones or cancer. Elevated bilirubin can also be seen in liver disease, such as hepatitis or other liver diseases. LDH, which stands for lactate dehydrogenase. This is an enzyme that is ubiquitous, meaning it's in all cells in the body. Again, it's a very non-specific indicator of disease. It means that there's cell damage somewhere in the body. So we can see elevated LDH with acute or chronic cell damage, chronic inflammatory damage. We can see it with cancer. We can see it with liver disease. We can see it with muscle injury. But again, it's non-specific. It doesn't point to any one specific disease. Alkaline phosphatase. This is an enzyme that's produced in both the liver and bone. We can see elevated alkaline phosphatase, particularly in liver disease that causes bile duct obstruction. So a stone causing a bile duct obstruction or a cancer causing bile duct obstruction can elevate the alkaline phosphatase. We can see it with bone diseases, so we can see it with things such as metastases to the bone or something called Paget's disease. There are ways to what we call fractionate the alkaline phosphatase, tell bone from liver, but an easier way is to look at other liver enzymes to determine whether that alkaline phosphatase is coming from the liver or not. AST, that's called aspartate aminotransferase. This is another enzyme that's produced in many tissues, including muscle, liver, as well as red blood cell. Again, we use it mostly to look at liver disease. So when we have liver disease such as hepatitis, cirrhosis, or other liver diseases, the AST can be elevated. ALT, that's alanine aminotransferase. This is again something that's produced by multiple cells, kidneys, heart, muscles, pancreas, and liver. Again, we use this to look at liver abnormalities. So when the ALT is elevated, that gives us an indication that there's abnormalities of the liver, particularly in chronic liver disease. So this can be elevated in cirrhosis, it can be elevated in fatty liver disease, it can be elevated in chronic hepatitis. Iron. Everybody's heard of iron. You can't live without it. It's an essential part of hemoglobin, and hemoglobin is the molecule that carries oxygen to all of our tissues. 70% of all iron is stored in the hemoglobin molecule in red blood cells. We've all heard of iron deficiency anemia. That means we have too little iron. That can be caused by blood loss in women from menstruation. In men or women, it can be caused most commonly from GI blood loss. Elevated iron levels can be seen in a disease called hemochromatosis. Triglycerides. Triglycerides are basically fat. They're fat molecules that are manufactured by our liver, circulate in the blood, and then are stored in tissues such as adipose tissue or muscle. Triglycerides are really driven by the consumption of carbohydrates and sugar. So if you want to lower triglycerides, lower your starchy carbohydrate consumption and sugar consumption. Triglycerides are a risk factor for cardiovascular disease. There are familial incidences of hypertriglyceridemia where abnormally high triglycerides run in families, but this only affects a very small percentage of the population. Most people with elevated triglycerides, it's because they eat too much sugar and too many refined carbohydrates. GGTP, gamma-glutamyl transpeptidase. This is a long word. It's an enzyme that is again produced in the liver. It's also produced in the spleen, kidney, and prostate. It's a very sensitive indicator of liver disease. It's seen with abnormal diseases of the liver, such as alcoholic liver disease. It's also seen with acute inflammation of the gallbladder, as well as acute blockage of the bile ducts. It's less elevated in people with hepatitis compared with AST and ALT. Anion gap. Now this is a measurement of the difference between positively charged elements in the blood and negatively charged elements. So the positively charged elements are potassium and sodium. The negatively charged elements are chloride and bicarbonate. And it's the difference between those two. So you can have an abnormal anion gap seen with states of acidosis, and that's more complex to get into the acid-base balance than we will in this talk. BUN creatinine ratio. So this is a ratio of blood urea nitrogen to creatinine. This ratio can be elevated particularly in dehydration, congestive heart failure, and GI bleeding. It just tells us that there's abnormally high blood urea nitrogen compared with the creatinine. The AG ratio, which is the ratio of albumin to globulins. So globulins are a protein in the blood. As we talked about before, there's three main classes that make up total protein: albumin, globulins, as well as fibrinogen. It's just basically a ratio of albumin to the globulin level in the blood. This ratio can be elevated when there is elevated albumin, such as in a high-protein diet. This ratio can also be elevated if there's hypoglobulinemia, meaning there are too few globulins in the blood. This ratio can be low with malnutrition. Anything that lowers the albumin will lower the AG ratio. So globulins. Globulins are a class of proteins in the blood. There's several different classes of globulins, but basically many of them have an immune function. So the globulins are important in immune function. They're manufactured by the liver. They're manufactured by lymphatic tissue and other cells. So you can see low globulins in malnutrition, nephrotic syndrome where we spill protein in the urine. We can see elevated globulins in acute infection, chronic inflammation, multiple myeloma, or if you have a state of decreased albumin. HDL cholesterol, high-density lipoprotein cholesterol. So HDL cholesterol means that it's a protein that carries cholesterol and fat. We've labeled HDL cholesterol as, quote, good cholesterol, meaning it's good for your body and reduces your risk of cardiovascular disease. It basically recycles LDL cholesterol and takes it back to the liver. LDL cholesterol, we've all been taught, low-density lipoprotein cholesterol, is cholesterol that's bound to a different lipoprotein and is carried around the blood and deposited in the arterial system, increasing the risk of cardiovascular disease. We want lower LDL cholesterol and higher HDL cholesterol. In order to do that, we can change how we eat. So if we look at people with metabolic syndrome, which is really driven by sugar and some starchy carbohydrates, that lowers HDL and raises LDL. By changing our diet, by getting rid of sugar, getting rid of starchy carbohydrates, we can actually reverse this. Exercise will also increase HDL levels. So we look at the cholesterol-HDL ratio. This is the ratio of total cholesterol to HDL. And if that ratio is less than 3.5, that's a good indicator that you have a low risk of cardiovascular disease. There may actually be a better ratio that we should look at, and that's your triglyceride to HDL ratio. That ratio should be ideally less than 2 to 1, but also if anything less than 3.5 to 1 gives you a low risk of cardiovascular disease. GFR, this is called glomerular filtration rate. This is a computed lab test. So we look at the creatinine, we plug it into a formula that takes into account the patient's creatinine, the patient's height, the patient's weight, the patient's age, the patient's ethnicity, and we come up with how well the kidneys filter. Other lab tests we'll talk about is a complete blood count. This includes a white blood cell count. So white blood cells are immune cells. They're infection-fighting cells. So elevated white blood cell count can be seen in acute infections, chronic infections. It can also be seen in leukemias. Decreased white blood cell counts can be seen with marrow production problems such as acute leukemias or lymphomas. Red blood cell counts, these are the count that measures how many red blood cells we have floating around in our bloodstream. Decreased red blood cell count can indicate anemia of some cause. It could be a production problem in the bone marrow, or it could be a blood loss problem in the GI tract. Hemoglobin, this is a measurement of the molecule within the red blood cell that carries oxygen to our tissues. Hematocrit, that's the number of packed red blood cells, or the number of red blood cells per volume of plasma. So it tells us how many red blood cells are in a particular volume of plasma. MCV, you'll see this. This is called mean cell volume, and it's an indicator of the volume or size of the red blood cell. MCH means mean cell hemoglobin. Okay? What this tells you, it's an indicator of the average amount or weight of hemoglobin in a red blood cell. MCHC's mean cell hemoglobin concentration. This is the average concentration of hemoglobin within a given red blood cell. So these are all used to look for anemia. They're used to differentiate different types of anemia. So for example, if you have anemia secondary to blood loss and low iron, your mean cell hemoglobin and your mean cell volume will be low. If you have anemia secondary to folate or B12 deficiency, then your cells are too large and you have more hemoglobin in your cells than you normally would. So these help us differentiate different causes of anemia. Platelets, these are small cells produced by our bone marrow. Platelets are important for blood coagulation. They're the first line of defense when we have a cut or bleed. HSC, this is high sensitivity C-reactive protein. This is a measurement of total inflammatory change or inflammation in our body. This test has gotten a lot of attention lately. We know that many of the chronic diseases we experience, including cardiovascular disease, cancer, obesity, lung diseases, all these diseases we know now are chronic inflammatory diseases. Rheumatologic diseases all come under chronic inflammatory diseases. So we've had a lot of interest in measuring inflammatory markers in our body, and one of those is highly sensitive C-reactive protein. Now, we can measure this, but we're always not sure what to do with it, okay? So it's a test that is not really specific for any given disease, but it's a test that tells us there's chronically elevated inflammation in our body. The way to change that is change our diet. Hemoglobin A1C. This is basically something called an advanced glycation end product. Sugar molecule is attached to them, and that's what we measure. So hemoglobin A1C is a measurement of how well our blood sugar is controlled over about a 30-day period. This is maybe one of the most important tests that we have because we know chronically elevated blood sugars are associated with a whole host of diseases: stroke, dementia, cardiovascular disease, cancer. All these diseases are associated with abnormal blood sugars. Prostate-specific antigen, PSA, this is a marker for possible prostate cancer. Now, there are other benign causes of elevated PSA, including prostate infections and benign prostatic hypertrophy. A single PSA reading in and of itself is not really specific. What we look for when we draw PSAs is a trend towards elevation. TSH, called thyroid stimulating hormone. This is a hormone produced by our pituitary gland that stimulates our thyroid to produce thyroid hormone. When we have high TSHs, that means our thyroid is not working as well and that we may need thyroid supplementation. When we have low TSHs, that may be an indication of a hyperthyroid state where our thyroid is producing too much thyroid hormone. Vitamin D. So vitamin D is a really interesting vitamin. It's actually been reclassified as a hormone. And we found it to be extraordinarily important in many, many different diseases. So we can make vitamin D naturally. Go expose yourself to a half hour of sunshine a day and you'll make all the vitamin D that you need. Now, being in northern latitudes, we do not get enough vitamin D because we don't get enough sun exposure during the winter. So we should be supplementing with vitamin D, and it is important to get our vitamin D levels greater than 30 nanograms per milliliter, which is the normal cutoff. This can be done with either going out into the sun or it can be done with vitamin D supplementation. We know that vitamin D is important for many different disease states. Vitamin D is important for the prevention of cancer, heart disease, hypertension, diabetes, and even depression. So get your vitamin D up. Go out and enjoy the sunshine. Vitamin B12, vitamin B12 is interesting. It only comes from animal products, so if you're a vegetarian, you're going to have to probably supplement with vitamin B12. But vitamin B12, if you look at energy drinks and some of these 1-hour energy drinks or shot energy drinks, they all have vitamin B12. Well, vitamin B12 is essential for production of red blood cells. It's essential for neurologic function. Again, dietary sources are any animal-based product. Most of us who eat animal-based product will not be deficient in vitamin B12. We can see deficiencies in vitamin B12 in people with something called pernicious anemia, where they cannot absorb vitamin B12 effectively. We can see vitamin B12 deficiencies in vegetarians. We can see vitamin B12 deficiencies in people who have a gastric bypass or other malabsorption syndromes such as celiac disease or inflammatory bowel disease. that runs the gamut of everything. I hope that this was helpful. Remember, if you have an abnormal lab test and you're not sure what it's due to, make sure that you talk to your physician about it. Thank you.